Hello, my name is Lydia McGrath and I am a senior majoring in nutritional sciences. Today I'll be presenting on the topic of malnutrition in critically ill patients. Here's a brief overview of this presentation. I'll start out with an introduction, then discuss the prevalence and consequences of malnutrition in critically ill patients. I'll then discuss strategies for preventing and treating malnutrition in this population, and wrap it up with a conclusion. So before we talk about malnutrition in critically ill patients, it's important that we understand who these patients are. Critical illness is a catabolic stress state. It's associated with complications such as increased infection risk, multi-organ dysfunction, prolonged hospitalization, and increased mortality risk. When discussing malnutrition, critically ill patients are an important group to focus on, since they face an increased risk for malnutrition due to the inflammation and metabolic changes associated with their condition, as well as inadequate nutrient delivery. So first, let's discuss the prevalence of malnutrition among critically ill patients. This data was obtained by a systemic review of 20 studies. It outlines the prevalence of malnutrition in heterogeneous critically ill patients, as well as the prevalence in specific critically ill patient populations. What I'd like to point out here is that malnutrition rates in critically ill patients vary widely, but the general prevalence among heterogeneous critically ill patients is somewhere between 38 and 78%. The variation in these numbers can also be explained by the different diagnostic methods used throughout these studies, as well as the fact that some patients may not be malnourished when admitted to the ICU, but may develop malnutrition later on throughout their hospital stay. Also, in one of the included studies in the systemic review, malnutrition prevalence was higher in the ICU compared to the general ward, with rates of 54.8 and 41.2 respectively. Another study included found that the risk of developing malnutrition was statistically higher in ICU patients compared to general ward patients. Malnutrition has significant consequences in critically ill patients, including adverse clinical outcomes while in the hospital. For example, malnutrition is associated with increased ICU length of stay, increased incidence of infection in ICU patients, increased ICU readmission rates, and increased hospital mortality risk in ICU patients. There are also substantial financial consequences associated with malnutrition in critically ill patients. For instance, the average cost per patient is up to 6.5 times higher for critically ill malnourished patients compared to general ward malnourished patients. The consequences of malnutrition in critically ill patients also extend beyond the hospital setting. For instance, in an observational cohort study of over 23,000 patients, researchers examined the effects of malnutrition on post-discharge outcomes in critical illness survivors. They looked at the following three outcomes: 30-day hospital readmission, discharge to a care facility, and 90-day post-discharge mortality. The researchers found that in patients diagnosed with any protein energy malnutrition, the odds of 30-day hospital readmission were 2.1 times higher than in patients without malnutrition. The odds of being discharged to a care facility were 2.7 times higher in patients with malnutrition present compared to those without malnutrition. And the odds of 90-day post-discharge mortality in patients with any protein energy malnutrition were 5 times higher than in patients without malnutrition. This study shows that post-hospital discharge consequences of malnutrition in critically ill patients are significant, highlighting the importance of treating malnutrition early on and continuing to monitor nutritional status after hospitalization. So we've established that malnutrition in critically ill patients is an important issue to focus on. So what can be done to address this issue? For the purpose of this presentation, I'm going to focus on the role of the healthcare professional, since many of us are students aiming to enter a healthcare profession. So first off, clinicians should perform early nutrition screening, followed by nutrition assessment. Nutrition screening should be performed using a validated nutrition screening tool, such as the MST or the malnutrition screening tool. Clinicians should provide sufficient energy and protein to meet the nutritional needs of these critically ill patients. This is crucial in offsetting muscle loss and preventing adverse health outcomes, such as those mentioned throughout this presentation. The value of meeting these patients' nutritional needs has been demonstrated through research. For example, one study found that achieving at least 80% of patients' protein needs was associated with reduced mortality in ICU patients. Oftentimes, oral intake in critically ill patients may be insufficient, meaning that the patient is unable to meet at least 70% of their energy needs through oral feeding, or it may not be possible, such as for patients on mechanical ventilation. In these cases, clinicians should use nutrition support, which includes enteral and parenteral nutrition. With enteral nutrition, formula is delivered directly into the gastrointestinal tract, bypassing the oral cavity. With parenteral nutrition, formula is delivered intravenously directly into the bloodstream, such as through the superior vena cava. If a critically ill patient is unable to eat by mouth but has a functioning GI tract, then enteral nutrition, or EN, should be used. EN should be initiated early on, within 24 to 48 hours. The provision of early EN is associated with positive outcomes, including significantly improved patient survival and total healthcare costs. When the critically ill patient's gastrointestinal tract is not functional, or if the patient is intolerant to enteral feedings, or if they require an escalating vasopressor, then parenteral nutrition should be used. While the safety of parenteral nutrition has been a source of speculation, research has shown that parenteral nutrition is a safe and feasible option for patients who cannot receive enteral nutrition. For example, recent studies have shown no increased infection risk and no difference in mortality with parenteral nutrition. After beginning nutrition support, clinicians should monitor patients who are on nutrition support and continue the enteral or parenteral feedings until the patient is able to feed sufficiently by mouth, meaning that they are able to get at least 75% of their energy needs through oral feeding. So in conclusion, malnutrition is widely prevalent among critically ill patients due to factors such as inflammation and the metabolic changes associated with critical illness. There are considerable health-related and financial consequences associated with malnutrition in critically ill patients. These include poor clinical outcomes in the hospital, increased healthcare costs, and poor post-discharge outcomes. Clinicians do play an important role in addressing this issue, and there are various actions that clinicians should take to prevent and treat malnutrition in critically ill patients. Clinicians should perform early nutrition screening and assessment in order to identify malnutrition risk early on. They should provide sufficient calories and protein to meet the patient's nutritional needs and begin nutrition support when oral intake is inadequate or not possible. Shown here are my references, and I want to thank you all very much for listening to this presentation. I hope you learned something new, and if you have any questions, feel free to contact me at my email, which is shown here. Thank you.